Hi, hello, welcome back. Last week I left you people on the slide on what are the challenges to implement evidence-based medicine and value-based healthcare in radiology. So we'll be uploading these videos at appropriate intervals. Maybe you would get it at the same time as well. The next part of this lecture, I would say a discussion, is on explaining how do we incorporate evidence and value into practice. This might seem a bit boring for some of you, but this is probably the basement or the concepts behind our initiative webinars. So I would like to dwell a bit more on that. So as we see, value is something that is very difficult to measure, and that's the main challenge here, especially when it comes to evidence-based medicine. So what is evidence-based imaging or radiology? We must realize at the end of the day, when we do something, we need to be realistic or practical about it. And even in real life situations, we need to be sensible most of the times. So, how do we incorporate this evidence into a practice? In essence, it is nothing but an amalgamation of three topics here. One is how much expertise you have in the subject. Second, what is the preference and the value for the patient who is coming to meet you? And what is going to be the evidence out there on this particular topic for which the patient has a problem with. And if you see, the overlapping part of these three circles is going to be our emphasis in being able to practice evidence-based medicine. If we can combine our expertise with the patient preferences using the available evidence, we would probably be close to achieving evidence-based practice. So how do we then do or research for this evidence-based? And this is something that clinical people do a lot. They do read a lot of research articles. Unfortunately, radiology, I think, lags behind in collecting and reading evidence. And it's not very difficult. Nowadays, we know that it's almost certain that a resident who comes into radiology is going to end up having a smartphone or a laptop-based approach to radiology. Textbooks have kind of given way to more of online teachings and on the spot reading. And I would suggest, instead of going not just for sites like Radiopedia and other, which is very good in terms of giving you at hand immediate kind of reads, whenever you get time, you can always go through the available evidence and see how much of quality is there in that evidence. And when we say what is the level of evidence, how can we trust the data that comes out? So it's very simple. It is an hierarchical model. As we can see, any research that comes out of animal and laboratory studies, or those which just involve few patients or a few case reports, are at the bottom of the pyramid. And once you start having a larger database, which could be a case control study or other non-randomized studies, it comes slightly higher in the hierarchy. And at the top of the pyramid would be the ones that are rigidly conducted randomized control trials. And sometimes we go even further and conduct a systematic review or a meta-analysis of all the previous studies. And that would occupy the top of the pyramid. And as we can see, most of the guidelines incorporate these as their level A, B, or C of the evidence. And how do we incorporate it into our practice? Obviously, it starts with one clinical question. What are we trying to answer here? And that is the first step in evidence-based practice, asking that question. The second step would be to acquire the knowledge or evidence for answering the first question. And it's not just looking at one isolated case report. We also need to analyze what is the level or quality of that evidence, which means we have to appraise whatever we are reading. Is it an isolated case study? Is it an anecdotal report? Or is it a very strong randomized trial? And once we do that, the fourth step would be to apply that in our practice. So we'll go back to the patient and say, this is what the current evidence shows us. And finally, what if the real life practice is different from the results that come out even in trials? So we need to audit, and in terms of what happens to the patient from their own personal experiences, we use the outcomes of our patients to see whether what we applied also holds true in real life practice. And this is kind of a recurrent cycle. And whatever you see in your textbooks most likely comes from these studies that have been conducted 5 or 10 years earlier, which means textbooks can easily become outdated these days. And before the blink of an eye, you would have another study that answers the question differently, or even throws out contradicting evidence. And we need to be updated about this all the time. So how can we become a clinical radiologist? First and foremost, we need to identify ourselves as a problem solver. And this is central to patient care. And we need to be aware of all the rapidly advancing new techniques. And we need to ensure that the dependence on us on imaging in terms of the old management increases. And for that, we have to be very innovative and challenging. So do you want to practice just specialty or general radiology? It would again depend on how much volume load is there. And at the end of the day, obviously a work-life balance is imperative for any kind of professional advancement. There are two approaches to radiology that you can take. One is what our seniors teach us, or what we listen to in terms of more experienced practitioners. And that is called an eminence-based radiology. But it's slowly giving way to what we call as an evidence-based radiology, the one that is based on the literature evidence, our own practice, and our appraisal of that. And here it's no longer it's about one's subjective opinions. We need more of objectivity too. And this creates impact not just on the diagnostic performance, but on all levels, including the outcomes of the patient at the level of society. What are the resources available for us to do this? Obviously, the largest resource base is the PubMed. And some of the articles are unfortunately under embargo or they are not free for access. In countries that allow certain websites to function, you can always access such resources and see if you can get the full version of the articles you're searching for. It's not just for articles, you can have websites for textbooks as well. So finally, when it comes to a radiology resident, I would advise that we need to commit ourselves both in terms of an individual level and to the community level of trying to first and foremost fulfill our commitment to the patient, which means try to extract as much clinical information about the patient as possible. We need to fulfill our commitment to the clinician, which involves reporting any kind of critical findings. And I would say not just reporting, but communication of that reports in a timely fashion. Go back to any kind of discrepancies that may arise and be fair to acknowledge them. And at the end of the day, always keep documenting all these communications that you do. What would be the steps would be as the same as any other specialty. And we try to read science in radiology. It's again, what patient groups are we studying? What is the intervention, which means the imaging modality that we are doing? What is going to be our comparative? And what is going to be the outcome? And this is a practice that keeps on repeating in any field. And evidence-based medicine can allow you to do what is called a practice-based learning. And I would also probably look at major institutes shifting towards this kind of practice because it can empower the resident to become problem solvers. So what does it involve? It involves a mixture of a child-like learning, which is more didactic, to something that is more adult-centric learning, which is independent. So we give you a mixture of lectures and modules. We make you better in what you're doing. And at the same time, we allow you to be independent as time goes on. And it's not just in individual, we can leave you in groups. We can have a couple of residents rotating. We can have detailed sessions on how you interact, not just in the department between the staff, but also among each other. And then go on to have questionnaires and other kind of modules. So we can keep on improving this process or evolving it. So we must understand by using value and evidence, we're not just improving our technical efficiency, we're improving the diagnostic efficiency, creating an impact that's not just at the level of the diagnosis of the disease, but it creates an outcome, both in terms of therapeutics and patient outcome. And when you start creating differences in patient outcomes, it ultimately leads to a socioeconomic benefit. How do we do that? So how do we calculate this value? Value is nothing but it's defined as the outcome per cost. And the outcome would also depend on the quality of the service being provided. And at this moment, even though these are non-tangible measures, we are trying to go towards measuring these metrics, and hopefully in future, probably a patient would value the quality of the service being provided, not just in terms of ruling in a disease, but even ruling out of disease and answering the question for which he's there in the first place. So that's what value-based healthcare is all about. It has a personal values because we use the appropriate care to achieve their personal goals. What does the patient want? It has technical value because we're using the best possible outcomes. We are trying to achieve them with the available resources. Simple example, if you don't have an MR available, what is the next best option? It also has allocative value because we can't have allocating resources to all the patient groups. We'll have to adjudicate who gets to get what in terms of emergent care. And finally, when we start practicing value at all levels, it's going to have an overall societal value where we contribute to the general health care of the population. A couple of slides which might seem a bit statistical, but in essence, it's not. I can say that biostatistics is found to be boring by many people, but biostatistics is at the heart of any radiology. And if you want to practice something called GCP or good clinical practice, especially in radiology, the concept of likelihood ratio is very important. When a patient comes in for a diagnostic test, we have a pre-test likelihood ratio that the clinician gives us. What is the probability that this patient is going to have the disease that is suspected? And then we use a test that is usually having high specificity as well as a high sensitivity. And we use a trade-off between these. So what do I mean by specificity? It means that a positive test result is going to effectively rule in the diagnosis. And when I say a test has high sensitivity, a negative result is going to rule out that disease. And then we get a post-test likelihood ratio. And what is this likelihood ratio? When I'm going to test that in a disease patient, how often I'm going to get that test right, as opposed to the probability of the same result in patients who don't have the disease. And this is at the heart of any diagnostic test that you do. So we could have a threshold for exclusion, which is called an exclusion threshold, and a threshold for action, which is the inclusion threshold. And we are trying to increase these threshold levels before and after doing the test. In either ruling out, in which case we decrease it as much as possible, or ruling in which we try to increase it as much as possible. I hope it clarifies a little bit, but this is just an introduction towards how we should practice value and evidence. So final summary, we need to understand radiology is not about diagnosis anymore. It's also about prevention, detection, prognostication, delivery, and of course, intervention. If you're a radiologist and if you're planning to specialize, I would advise clearly demarcating your profiles separately for outpatient scans and for inpatient imaging. You could be doing a primary reporting. You could give an opinion on a patient that has already had a radiological report. You would start getting direct referrals for clinical opinions in terms of what would be the ideal imaging modality, interpretation of a particular result, and what next to be done with that patient. When it comes to inpatient imaging, beware that many of them are incomplete studies, and you could still add value by picking out subtle findings or findings that changes the management for a really sick patient. You can't expect to have the best modality with the highest quality for these patients. You get to be a part of a clinical radiological system, the pathway where you're also part of the decision making. You also get to play a role in academics, and it's going to be an ongoing process. And finally, radiologists need to be a part of the administration as well. So at this point, I would just finish my introductory lectures to the webinars concept, which tries to incorporate both value and evidence into clinical practice for radiologists and any of the other people who are interested in neuroimaging. Thank you.